Hi everyone, I want to talk to you about hematuria, which is also known as blood in urine. Blood in urine, hematuria. It can be microscopic. In other words, can't be seen with the naked eyes. Or macroscopic, which means the blood in urine is visible to the naked eye. The period during urination can give clue to where the problem has come from. If the patient presents with history that the first thing I will notice while trying to pee is the blood, that is initial period of urination, then the likelihood of urethra being the source of the trouble is high. But if the patient says, I will see blood from beginning and throughout the time I pee, that is total, then that is likely from ureteral or kidney problems. But if the patient says, no, the blood is at the end while rounding up, I will not say the first thing, and not throughout the time I pee, but while rounding up, that is when I'll see the blood. Then that is terminal, and that is likely a problem with bladder neck or prostatic urethra. What are the possible causes of hematuria or blood in urine? Benign prostatic hypertrophy in men or prostatic carcinoma in men. Urinary tract infection, kidney stone, inflammation of the bladder called cystitis, cancer of the bladder, cancer of the kidney, cancer of the prostate, or prostatic enlargement. Could be as a result of trauma or the use of blood thinners, otherwise known as anticoagulants. Liver failure. Why would liver failure be a differential diagnosis here? Yes, it could be because liver is responsible for the production of all clotting factors except two. And which are they? Von Willebrand factor and factor 8. Those are the only ones not produced in the liver. So when the liver has failed, we have a problem with bleeding. And bleeding dyscrasia is another possibility. If the individual has been diagnosed with bleeding dyscrasia before, then it is not new right now. Foreign body along the urinary tract system, medications like rifampicin. Is this person on rifampicin to treat tuberculosis or anything that's used rifampicin for? Or this is urethral stricture. Maybe a procedure has been done before, or instrumentation like catheterization, and now we're having problem as a result of trauma there. Hydronephrosis is also a possibility here. Is this person having died or beat? And sometimes hematuria could be as a result of exertion, rigorous exercise. Any possibility of glomerulonephritis here? Or if it is a woman, any bleeding here like regular menses mixing up with this urine? It could be trivial, like I presented it now, but that could be a clue, and then there'll be less worry. Or is there any hemolytic process going on? Maybe this is hemoglobin from hemolytic anemia. Is this person on medication like statins to fight cholesterol and now having rhabdomyolysis, and we're picking myoglobin there because naked eye will not be able to distinguish that. Phenazopyridine on phentoin can also give us this. Porphyria, tuberculosis, Wilms tumor, polycystic kidney disease, infarct, or arteriovenous malformation. Hematuria could be associated with upper respiratory tract infection, in which case we'll be dealing with glomerulonephritis right now and immunoglobulin A nephropathy. It might be obstructive uropathy, and the history will involve while trying to pee, there'll be hesitancy, incomplete emptying feeling, post-nutrition dribbling, weak stream, and straining to void. Then we'll know we're dealing with obstructive uropathy like benign prostatic hypertrophy, prostatic carcinoma, or urethral stricture. Is it possible this is an irritated bladder? And in that case, we have history of frequency, urgency, nocturia, and dysuria. So are we dealing with cystitis or urinary tract infection? There's possibility of infection going on, like I've just mentioned, and you can have, in addition to irritable signs, you can have pyuria, dysuria, and fever. But let me drop a note here. In elderly men and women, you may not see fever, yet they can have urinary tract infection. Is this kidney stone? In that case, the history will involve flank pain, and the pain might be radiating to the suprapubic region with associated nausea and vomiting, and then hematuria. What investigations are we going to carry out here? Let's have complete blood count done. Let's get the electrolyte level, blood urea nitrogen, creatinine. What is happening to INR and PTT? Haptoglobin, is it down now? What about urinalysis? RAM, microscopic culture and sensitivity in case we are suspecting urinary tract infection. Ultrasound of the pelvic region showing kidney, urethra, and bladder. How about CT to be definitive, and cystoscopy if we are suspecting problem with the bladder itself. Treatment here will involve copious irrigation of the bladder with continuous bladder irrigation. If we could pick any active bleeding based on the outcome of investigations done earlier, we have to coagulate the bleeding arteries. We'll refer to oncologists if we find any resectable tumor. Embolization or ligation of iliac arteries as the main source of blood supply to that region is necessary. Cystectomy or diversion is possible. Nephrostomy tube and transfusion if required, that is, if this patient is becoming hemodynamically unstable, or the complete blood count is giving a feature of anemia with other physical symptoms. If we have identified any medication as being the culprit, we need to stop that. For example, if it's anticoagulant, discuss with the doctor in charge of whatever situation that has led to the prescription of that and see what you can do about it. But that is not anything to do about rifampicin, like someone is having TB and is on rifampicin, you don't have to stop rifampicin because you think the color is changing because of rifampicin. I need not to say that. No, it's just changing the color. It's not altering the blood level of the affected individual. Antibiotics as may be required if you are dealing with urinary tract infection, and kidney stones will even be dealt with separately later on, but quickly it's possible that extracorporeal shockwave lithotripsy could be done, and if it is bigger, you can have percutaneous nephrolithotomy. And the ideal thing is once you are able to pick the cause, refer to nephrologists or oncologists as may be appropriate. In conclusion, it may not be a big problem if an individual is having hematuria, but we need to know the cause. And that is why it is proper to approach your doctor, who will carry out necessary investigation after the history and physical examination, and you might be referred appropriately to oncologists or nephrologists. Thank you for listening to my presentation. Kindly subscribe so that you can have these presentations immediately they are published. Thank you.